Thank you so much for joining me today. My name is Jenna Tosto-Mancuso. I am a physical therapist, a board-certified clinical specialist in neurologic physical therapy, and the clinical director of the Abilities Research Center at Mount Sinai. And today I have the opportunity to discuss with you autonomic rehabilitation for long COVID. So in my talk today, I hope to discuss with you some of the underpinnings that drive autonomic dysfunction in individuals with long COVID and present to you some of the recent research and best practices that our team has developed for addressing autonomic rehabilitation for individuals with long COVID. And so as our previous talks have discussed, there are several founding facts that have been recently discovered identifying what is known and what is not known or new about long COVID. So what is new and recently discovered is that individuals with long COVID can experience up to 200 symptoms. That's an estimated 10 to 30% of the population with anticipated to experience symptoms of long COVID. So on average, we're estimating about 4 million individuals with long COVID in the US alone. And those numbers are staggering and more or less going to cross our clinic at some point in our practice. So as physical therapists and providers of rehabilitation, it is in our best interest to arm ourselves with knowledge and best practice to better serve those experiencing these wide variety of symptoms. So when we look at the clinical presentation of long COVID, we start to identify a series of symptoms and clinical phenotypes that are suggestive of dysautonomia. And so when we think about symptoms like postural orthostatic tachycardia syndrome or POTS, inappropriate sinus tachycardia, post-exertional malaise and post-exertional symptom exacerbations, hypocapnia, dizziness, and chest pain, to name a few. Again, those symptoms in isolation might be a bit confusing, but when we put them in the context of long COVID, we start to suggest a dysfunction of the autonomic nervous system or dysautonomia. And so there are two primary leading theories right now suggesting why those symptoms and those syndromes present. The first being an inflammatory and an immunological response to the acute COVID-19 infection, as well as the role of autoantibodies and autoimmunity in the presentation of long COVID. And so what I hope to present to you now is some data that our group recently published looking at some of the demographics of individuals with long COVID. So as you can see here, we present data looking at all patients in a cohort of 156 that came to our clinic in our very early stages of our care of patients with long COVID. And so you can see some staggering and really important facts to note. Number one is the median age for individuals. The median age for individuals with long COVID was 44 years old. So really important to note that the individuals who will be coming to your clinics and your clinical practice, they are of an average age. They are not individuals who we initially suspected might present with long-term complications from COVID-19, that being older adults or those with significant comorbidities. So again, really important to understand the demographic of who's coming to your clinic. Likewise, looking at comorbidities that may be presenting in your patients, always want to take those into account, especially as you're taking your patient histories and painting the clinical picture of the individual you'll be providing care for. And so some of the more prevalent comorbidities that we identified in the cohort included any type of cancer, asthma, anxiety, depression, and hypertension. So just again, keeping note who is coming to the clinic. Additionally, and as I noted early on, presentation with long COVID can be that of over 200 symptoms. And so some of the primary symptoms that our cohort noted was that of fatigue, brain fog, headache, sleep disturbance, and dizziness. But as you can see, there is a myriad of presentations and all are consistent with dysautonomia. So things like sweating or thermoregulatory differences, tachypnea, or differences in GI function, bloating, any symptoms related to hair loss, sore throat, any of those symptoms that, again, in isolation may be obscure, but when we paint them in the picture of dysautonomia, they start to make a bit more sense. As physical therapists and rehab providers, I really think this next statistic is incredibly important for us to understand. So when we look at individuals coming to our clinics with long COVID symptoms, 86% of individuals in the cohort we published on reported physical exertion as a primary trigger of symptom exacerbation. 86%. As rehabilitation providers and physical therapists, it is paramount that we take into account the role of physical therapy and rehabilitation, especially interventions that promote physical activity, and how those interventions might trigger symptoms. So really being keen to pay attention to our patient reports and really look out for the risk of post-exertional malaise and post-exertional symptom exacerbations. Likewise, stress is reported in 69% of individuals as a trigger of symptom exacerbations. Now, it's important to remember that stress can be both physical, it can be cognitive, and it can be emotional. So any type of stressful state can be a risk for symptom exacerbations or a trigger for symptom exacerbations in our patients. So as we're designing rehabilitation and physical therapy interventions, we really want to be keen to focus on those reports of symptom exacerbations and how our interventions impact our patients. Likewise, very, very important to consider fatigue. As we noted early on, fatigue being one of the more prevalent symptoms reported by individuals with long COVID, 78% of individuals reporting debilitating fatigue as measured on the fatigue severity score. Likewise, 40% of individuals were reporting debilitating dyspnea as measured by the MRC breathlessness scale. And so we really, again, looking out for patient reports, it is not only important to look at our objective metrics, which we'll talk a bit about later in our presentation today, but also honing in on the patient-reported and patient-reported outcomes. So a few more key points of data that I think are very important to share as we start investigating and understanding rehabilitation and physical therapy interventions for our patients with long COVID. As I just noted, when we think about stress and we think about symptom exacerbations, one of the key facts we also want to consider is that manifestation of symptoms is not only physical. Cognitive impairment and brain fog is frequently reported in individuals with long COVID. And so as you can see, the staggering statistics demonstrate that at least mild impairment is reported in the majority of individuals with long COVID, especially looking more toward the moderate to severe level of cognitive impairment. So when we're thinking of exercise prescription and patient education, taking into account the role of brain fog in our modalities is going to be incredibly important. Again, another note of data that's very helpful for those of us on the physical therapy end and rehabilitation end to understand. The ability to perform moderate and vigorous intensity physical activity regularly pre and post-COVID was investigated in our cohort. And so if you look at graph A, where we look at percentage of participants who were able to perform moderate intensity physical activity pre-COVID. So if we look at our weekly report pre-COVID, we're looking at approximately 70% of participants. If we look at post-COVID, that number drastically changes to below 20% of individuals. Similarly, if we look at the report of individuals who felt they could never perform moderate intensity physical activity pre-COVID, those reports were relatively low. If we look at the percentage of participants who reported inability to perform any form of moderate intensity physical activity post-COVID, that number drastically rises. So really noting that moderate intensity physical activity was not well tolerated by participants when we compare from pre-COVID levels to post-COVID involvement. If we look at graph B, we're looking at vigorous intensity physical activity for individuals, and we see a very similar report, except highly amplified. So again, if we look at that weekly report of individuals who felt they were capable of performing vigorous intensity physical activity pre-COVID, we're looking at approximately 30% of individuals. That number drastically plummets post-COVID. Similarly, if we look at the reports of individuals who felt they could never perform vigorous intensity physical activity, again, we're looking at approximately 20% of individuals pre-COVID, and that number vastly increases for the post-COVID cohort. Again, really paying attention to the role of physical activity and how an individual experiencing long COVID may have the inability or have extreme difficulty participating in such an activity. And when we start thinking about our interventions as rehab providers, we often go to the ICF model. So thinking about how our patients and impairments in body structures and functions and environment can impact their ability to participate in day-to-day life and day-to-day roles. And so when we look at an individual's ability to work, I think this is very important to keep in mind as well, because ultimately as rehab providers, we are in the business of improving quality of life and participation. And so when we look at the percentage of individuals who had the capacity to work pre and post-COVID, again, full-time employment, that percentage of ability to participate drastically changes pre and post for full-time employment. Similarly, we see a vast increase in individuals who are unable to work due to their illness post-COVID as compared to pre-COVID. So we're seeing a significant change in ability to work and participate in day-to-day function secondary to post-COVID-19 conditions and long COVID. This slide here is taken from a collaborative group, the World Physio Briefing Statement number 9, looking at the key elements for safe physical activity and exercise prescription for individuals with long COVID. And so there are a few key points we want to keep in mind as rehab providers. The first is keeping an eye out for post-exertional symptom exacerbations and post-exertional malaise. And so by definition, a post-exertional symptom exacerbation is worsening of symptoms 24 to 72 hours or up to weeks following any physical or cognitive exertion. Now, what I think is very important to keep in mind, particularly in rehabilitation and physical therapy, is typically we assess capacity to participate and impact of an intervention within session. What becomes challenging when working with individuals with long COVID is we have to keep in mind that in session and while performing an individual intervention or a particular exercise or activity, while the patient is participating, they may not notice a change in their symptoms. But what is important to note is the capacity for post-exertional symptoms to become exacerbated, again, hours to even days or weeks after the fact. So while an individual may feel okay while they're performing an intervention, that does not mean that that is well tolerated and that it won't cause a symptom exacerbation thereby after. So some actions we can take as rehabilitation providers to make sure that we are on the lookout and appropriately addressing post-exertional symptom exacerbations. Number one, doing a symptom assessment during your session and following in the days and weeks afterward. So really engaging with our patients, checking in with our patients frequently to ensure that we are tracking their symptoms and their response to intervention. Additionally, a key component of rehabilitation programming for individuals with long COVID is that of symptom titration. What symptom titration implies is that an individual is consistently monitoring symptoms, and those symptoms are reported back to the provider. The intervention is titrated and modified based on the patient's report of their symptoms. So we take into account physiological metrics and exertional metrics, but we also highly prioritize patient report of symptoms, and we modify interventions again based on how those symptoms are impacting the patient. So we may ask an individual early in a session to rate on a scale of 0 to 10 their particular symptoms. What are those primary symptoms they're having, and how are they experiencing them at baseline? As we perform an intervention, we'll continue to ask the patient to rate their symptoms, and in the days to weeks afterward, again, ask the patient to rate their symptoms. With that aggregate data, we're able then to look at the intervention and modify based on those reports. So really, I say consistently, the idea of 3 sets of 10 is completely null and void here. What is incredibly important is listening to our patients and prioritizing that feedback as we change and modify our intervention. Other interventions or actions we can take to help individuals with long COVID in order to address post-exertional symptom exacerbation is number 1, to educate on, and number 2, to implement pacing and energy conservation strategies. So what that implies is educating patients on concepts like energy envelopes or spoons. So an energy envelope or the spoon count is a given amount of energy or capacity an individual has for activity in a given day. And that activity can be physical activity, it can be cognitive activity, it can be emotional activity. And what we encourage patients to do is to think about their capacity or their energy envelope for the day and to modify participation in day-to-day activities and tasks based on available energy. And so, in order to maximize participation in day-to-day activities, individuals are encouraged to pace themselves, to think about how the energy cost of an activity may impact their symptoms, and that same principle should be applied in rehabilitation and physical therapy. We should be thinking about how to implement energy conservation strategies and pacing strategies within our sessions so that we're consistently reinforcing the energy envelope for our patients. And along that line, and similar to what we've talked about, is the concept of identifying symptom exacerbating factors. What are those triggers of a patient's symptom exacerbations? And as we talked about earlier, physical activity, stress, dehydration, those are known triggers for patients, but every individual patient may be different. So really coming into the rehabilitation setting and to our physical therapy sessions with the goal of customizing and being patient-centered is incredibly important. The experience of rehabilitation and physical therapy for individuals with long COVID must be collaborative. It must be an initiative in which a sharing of information and feedback from provider to patient energizes and fuels the session at large. And so other considerations we want to keep in mind, especially when we're promoting and thinking of safety precautions, really thinking about cardiac or pulmonary impairments. So while individuals with long COVID oftentimes receive what we consider to be the $1 million workup, a workup of medical evaluations that are inconclusive or screen negative, we do want to take into account that based on the pathophysiology of COVID-19, individuals are at risk for cardiac or pulmonary impairment secondary to their acute infection. So before beginning a rehabilitation program with an individual with long COVID, we want to complete a cardiac screening or ask our physician colleagues or APP colleagues to complete a cardiac screen. And that might include an echocardiogram or an EKG, and thoroughly make sure that the medical team, in collaboration with you as a rehabilitation provider or therapist, is investigating causes of things like chest pressure and pain, breathlessness, tachypnea, tachycardia, palpitations, dizziness, and syncope, largely because the symptoms of autonomic dysfunction can mirror cardiac or pulmonary impairment. And we really want to make sure that we've ruled out any clinical red flags and the patient is safe to participate in a rehabilitation program. Similarly, when we look at dysautonomia, we want to make sure that we are completing as thorough an evaluation as we can, as well as to promote some conservative techniques for management of symptoms. So from a screening perspective, in clinic, and we'll talk of this a bit later, we want to complete an active stand test, which again, we'll talk a bit later about, but is a very great clinical tool that can be completed in session to evaluate a patient's autonomic status. We want to pay very close attention to signs of orthostatic intolerance or presyncope, as well as promote optimization of fluid intake, compression garments, electrolyte supplementations, sodium balance, etc. So those are some really helpful techniques that we've talked in previous conversations about in this presentation, but we do want to continue to promote for our patients in order to promote symptom stabilization. What I'm demonstrating here is some preliminary data from our functional outcomes, which is really setting the stage for what we're going to talk to next. And this preliminary data, it's not yet peer reviewed, but the preliminary data from our group looked at individuals participating in autonomic rehabilitation, individuals with long COVID participating in autonomic rehabilitation. And what we aimed to analyze was a report of performance in baseline and then follow up over the course of their continuum of care and rehabilitation. And what our data suggests thus far is that individuals with long COVID who are participating in autonomic rehabilitation are demonstrating a reduction in the number of symptoms reported from baseline to follow-up, as well as improvement on metrics, functional metrics like the 10-meter walk test and the 6-minute walk test, indicating improved endurance and improved activity tolerance. So some really promising data here that's setting the stage for the rehabilitation and the autonomic rehab protocol we're going to talk about next. So our program presents a 3-tiered approach to rehabilitation. And so the idea of the approach is to really encourage patients to and providers to take into account things like post-exertional symptom exacerbation, progressive intervention, and progressive conditioning, and really making sure that, again, we're staying patient-centered and patient-focused. So the initial evaluation should include cardiac clearance, as we stated earlier. So that might include capturing a past medical history, symptoms and exacerbating factors, patient-reported outcomes, and ensuring that a patient has completed an echocardiogram or an EKG or any additional tests that have been indicated by the medical team that better inform the patient's safety and appropriateness to participate in a rehabilitation program. From there, we like to start our patients with a prehabilitation, a 4-week program that emphasizes the introduction of breathwork exercise. And breathwork exercise is a great way, number one, of getting some ventilatory control for individuals with long COVID, promoting nasal breathing, and starting to address the imbalance of the autonomic nervous system. Now, when we talk about dysautonomia, we really need to keep into account the imbalance between the sympathetic or fight or flight portion of the nervous system and the parasympathetic, the rest and digest portion of the autonomic nervous system. And so breathwork exercise is a really great way of starting to drive balance in those two systems by driving parasympathetic activation and starting to promote balance. And the idea is if we can start to balance out those two systems, one being in overdrive versus the other, we start to gain a bit more control of symptoms and promote symptom stabilization. As patients participate in their 4-week prehabilitation program, we then begin them in a physical therapy program. And what the physical therapy program consists of is a low-grade, symptom-titrated rehabilitation. Sessions are typically 30 minutes each, one-to-one with a physical therapist, and they typically are held twice per week, with patient receiving a home exercise program to be completed in the interim. In phase 1 of the autonomic rehabilitation program, patients are progressed through an active range of motion, symptom-titrated activity program. And so we'll talk a bit more in depth about what that phase 1 might look like. Typically includes a progression from supine-based interventions to seated interventions to standing or upright interventions, with a focus on symptom stabilization, activity tolerance, and improved balance, again, of that sympathetic and parasympathetic autonomic nervous system. As patients continue to progress in the physical therapy program, they do graduate to the next level, phase 2, which is a submaximal aerobic conditioning protocol. And essentially, the submaximal aerobic conditioning protocol is adapted from the work of the Levine protocol, from the work of Fu and Levine 2018. Oftentimes as well, the interpretation of the Levine protocol can be found in the CHOP protocol, which is another variation, an interpretation of the Levine protocol that's very clinically friendly. So really thinking about progression into submaximal aerobic conditioning, largely because we know from literature in like conditions that we ultimately want to promote some degree of submaximal conditioning. But again, the key to getting to this is tolerance and symptom titration. How do we progress our individual patients? How do we progress an individual through the rehabilitation program? The primary metric that we look to track is the Borg rate of perceived exertion, or the modified Borg scale. So that using that 0 to 10 exertion scale, as well as a symptom VAS or visual analog scale. And as we talked earlier, we really want to track our symptom reports in patients, not only at the start of the session, but during the intervention, at the end of our session, and then in the days to weeks following the session to really ensure that our interventions and our progression remain symptom titrated. Additionally, we want to complete follow-up evaluations of individuals, typically completed every 3 weeks within the scope of the program, and that includes patient-reported outcomes, or PROs, and functional outcomes. And this aggregate data is incredibly important to us clinically to inform next steps and to track the progress of individuals in the program. So this is a sample of our supine symptom titrated therapy approach. And so as you'll notice, there are 4 primary interventions suggested. The interventions are all completed in supine, they're all active range of motion, and 3 out of the 4 are completed in an open chain fashion. And so the reason for that is we really want to focus on interventions that allow patients to recruit major muscle groups while still maintaining control of exertion and intensity. And so another detail you'll notice is interval duration. So instead of prescribing intervention in sets and reps, we recommend interval durations. So we look at starting at lower level time-based durations. So you'll see 30-second intervals to start bilaterally. And after each individual exercise, we have the patient complete a round of seated or supine breathwork exercise. So really going back to that prehab paradigm in which we implemented the breathwork exercise to drive symptom stabilization, recruit the parasympathetic nervous system, and balance out the sympathetic activation that is seen while the patient is performing that active range of motion intervention. Other key things to take note of, when we are working with individuals, we prioritize the rate of perceived exertion, or the modified Borg scale, RPE. And the reason we choose to prioritize RPE as opposed to a physiological metric like heart rate, which is typically seen in rehabilitation for other cardiovascular conditions or cardiac and neurological conditions, we prioritize the RPE because we anticipate, number one, with autonomic dysfunction, that heart rate response to intervention will be abnormal as based on the virtue of what autonomic dysfunction is. We don't expect to have normal heart rate responses with dysautonomia. Similarly, we anticipate that many patients may be taking medications that would modify heart rates like beta blockers. And so we choose not to use heart rate as a primary metric, but rather RPE, so we're staying very consistent with the concept of symptom titration. Things to keep in mind when we're assessing tolerance to an intervention and reasons why we might stop a protocol. Number one, if the patient is exceeding a target RPE of 3 out of 10 on that modified Borg scale, we want to keep interventions and exertion extremely light in this phase as we're looking to build symptom stabilization and stability and really promote introduction to movement. We also stop a protocol if a patient is reporting greater than 3 points of change on an initial visual analog scale score of a particular symptom. So if a patient's symptom is progressively worsening or rapidly worsening, we pause, we stop the protocol, and we reinstate breathwork exercise again to help stabilize. If a patient requests to stop, the task of beginning a therapy or an intervention program can be very challenging for our patients, and we want to work collaboratively as a dyad and respect our patients as we're prescribing an intervention. So if a patient is asking to stop, that is always a good place to stop. And rest breaks. If a patient requires greater than 5 minutes of rest between each of the interventions, it's typically a good indicator that the interventions we've prescribed are not well tolerated and we should pause for the day. What's important to note is that there is no particular time frame for progression out of phase 1 into phase 2 and so on. What's very important is to ensure that our patients are tolerating the interventions well and are not demonstrating exacerbations of their symptoms. So long as a patient is tolerating well and symptoms remain stable, typically we progress the intervention phase by phase between 1 and 2 weeks. As we progress into the next phase of intervention, phase 1B, we move from supine-based intervention to seated-based intervention. And so we maintain those same principles established in phase 1, including time-based intervals, use of a target RPE, and the same stop protocol criteria. But what is different is, number one, positioning, and number two, the number of sets performed of each interval. So really starting to slowly progress our patients as we go. Now, patients can continue to perform the exercises prescribed in phase 1A as a part of their home exercise plan, but in clinic, we're really focusing on introduction of the new sets of exercises so that we can view tolerance and see how a patient is responding to the intervention. Again, continue to monitor that VAS of the symptom reports, both within session as well as after the session, and in conjunction with the previously prescribed exercises. And so we want to be mindful of that to ensure that we're not causing a symptom exacerbation by adding new exercise or by progressing from supine to sitting. Similarly, as we move from progressing toward upright, we progress from seated exercise to standing exercise. And so you'll note again, there are the addition of new standing exercises. the intensity of the intervention increases, as does the target RPE. And so again, moving in the form of progression, listening to our patient's response to intervention and ensuring that this progression remains symptom titrated. If a patient is not tolerating this progression, we're seeing increases in their symptoms, they're seeing more frequent symptom exacerbations, we really want to take a step back. It's absolutely okay to move back from phase 1C to 1B or 1A, really meeting our patients where they are. I always say this truly at its core, we have to get away from the concept of no pain, no gain. It does not apply. One more repetition, pushing our patients, pushing, does not help here. In fact, we run the risk of exacerbating symptoms by pushing too hard. So really listen to your patients, get your visual analog scale scores and your symptom scores, and use that information in conjunction with the patient's reports to help progress forward. And so as we stated earlier, when we laid out our original plan for the rehab program, that first phase is solely focused on progression and tolerance of upright intervention and activity, and gaining symptom stabilization by promoting balance of the sympathetic and parasympathetic nervous system through balance of intervention and activity and breathwork exercise simultaneously. So keeping in mind that is the goal of the first phase. As patients tolerate, again, we move into the introduction of aerobic conditioning. And I should caution that this progression should not be taken lightly. We very much want to ensure that patients are well established in their preliminary phases before we progress to more intensive interventions. And that's largely keeping in mind the risk for symptom exacerbations and prioritizing symptom titration in intervention prescription. And so as we get into phase 2, like we had said, it is an adaptation of the Levine protocol. One of the more patient and provider-friendly facing interpretations of that is the CHOP protocol. And so in the early phases of this intervention, we focus on beginning patients with aerobic conditioning. And so what that aerobic conditioning consists of is use of a recumbent bike, or if a patient does not have access to a recumbent bike, the protocol recommendations can be modified so a patient performs them in capacity of overground walking. Where we deviate from the original literature and interpretation of the Levine protocol or CHOP protocol is in our clinical implementation. And this is really the translation of knowledge. And so we still continue to prioritize rate of perceived exertion, RPE, instead of target heart rate zones. Now, this is a bit non-traditional in the capacity of aerobic training because we largely focus in traditional aerobic training on the utilization of age-predicted heart rate maximum and certain percentiles of age-predicted heart rate max. But again, with dysautonomia, we would anticipate that heart rate response was abnormal and or a patient may be taking a medication that would lend itself to having an abnormal heart rate response anyway. So really thinking about how can we utilize RPE instead. And so there are 3 primary zones that we have patients working in. In the first 2 to 3 months of performing phase 2 and our goal of progressing toward discharge, we are utilizing primarily base pace and recovery pace. And there is a series of progressive interval-based training that has individuals initiate base pace training followed by recovery paces within an aerobic training session. We do not recommend going into the maximal steady state until symptoms are well stabilized and patients have been consistently performing base pace and recovery pace intervals over the course of, again, several weeks to months at a time. And this is largely to ensure that symptoms remain stable and intervention is symptom titrated. So by implementing these base pace and recovery pace intervals, we're still focusing on symptom titration based on the target RPE, but we are moving toward that patient-centered model and ultimately looking for this behavioral change and intervention to become a part of a patient's management strategy for their symptoms. Many patients with long COVID and other forms of dysautonomia continue to perform aerobic-based intervention and aerobic conditioning even after their discharge from rehabilitation, as it helps to manage symptoms and keep symptoms stable. So some clinical pearls and takeaways from our talk today. All activity should be symptom titrated. All activity should take into account where a patient's symptoms are beginning within session and how a patient is responding to the intervention after our sessions in the days and weeks following. RPE, or rate of perceived exertion, should be used as most patients will likely either be taking a beta blocker or have an abnormal heart rate response by virtue of having dysautonomia related to long COVID in general. Immediate use of graded aerobic exercise is not tolerated and is seen in other forms of POTS. So again, immediate use of graded aerobic exercise is not tolerated and not recommended by our group, as we really want to prioritize symptom stability for our patients before progressing to aerobic conditioning. Clinical decision-making should always be grounded in the goal of symptom stabilization and optimized activity tolerance. Again, that no pain, no gain, one more repetition mentality does not apply here, and in fact can make your patient's symptoms worse. So really take count of the patient's symptoms and aim for stabilization. Always feel confident bringing patients back to a level of tolerance, even if that means bringing them back to an intervention they had previously graduated from. And lastly, again, traditional approaches to addressing endurance and activity tolerance, they don't apply here. We really want to prioritize progression based on tolerance, not time. So there is no rush to push folks forward faster than they or their bodies are ready for. Really listen to your patient, take symptoms into account. And so as far as outcomes reporting go, we really want to make sure that we are being comprehensive, but also keeping in mind that the performance of functional outcomes can be taxing for individuals. So our group has prioritized several outcomes we feel give us the most amount of clinical knowledge for each of our patients. So number one, we look at demographics for our patients as well as a symptom checklist. We take orthostatic vitals of our patients in positions like supine, sitting, and standing, as well as completing an active stand test. Now, an active stand test is a test designed to evaluate autonomic function and autonomic control in individuals presenting in a clinic. Now, more traditional autonomic testing might include things like tilt table testing or pseudomotor testing, which we're not going to talk about in this course today, as we really want to maintain focus on clinical appropriateness for a rehabilitation or therapy provider. And so an active stand test is a test completed in clinic. It's a 10-minute test in which a patient is asked to stand with their head and their shoulders against a wall with their feet slightly in front of them. During the test, you'll ask the patient to have their shoes off so that you can see and observe their skin of their lower legs and feet. And you'll ask the patient to stand for 10 minutes. Every minute on the minute, you will assess heart rate, and every 3 minutes, you will assess blood pressure. And you'll track those metrics over time. And what you'll find is for an individual with autonomic dysfunction, this test is often very challenging and may be triggering of their symptoms. You might see significant increase in their heart rate. You might see changes in their blood pressure. You might observe changes to the color of their skin as well as the temperature of their skin. And patients may report exacerbation of symptoms or onset of pre-syncopal symptoms. What we want to keep in mind is we never want to drive a patient to the point of syncope, or if their symptoms are becoming significantly exacerbated, we don't want to drive them past the point of tolerance. So really take this test with a grain of salt and use clinical decision-making for starting and stopping the assessment, but it can be a very helpful tool for analyzing and assessing autonomic dysfunction and tolerance within a clinical setting. So definitely a great assessment to consider. And you'll find a link to this active stand test in our appendix as additional materials for you to consider using. And lastly, we implement a 30-second sit-to-stand test. And we choose to implement this test as it's a great metric for not only endurance, but muscle strength. And so again, really trying to be comprehensive in our assessment of our patients. So for patient education, we really want to continue to prioritize the collaborative relationship between patient and provider. So number one, we want to think about person-centered rehabilitation. So keeping in mind things like post-exertional symptom exacerbations, the role of symptom tracking, and the collaborative approach to care. We want to really hone in on pacing and energy conservation strategies, educating folks on stop, rest, pace. And lastly, thinking about the long story of long COVID rehabilitation. The rehabilitation process for long COVID is quite long and it's quite taxing. We want to be thinking of dysautonomia as a symptom of long COVID, with the goal of autonomic rehabilitation being stabilization of symptoms and symptom management. We really want to focus on the rationale for the selected interventions and provide education to our patients as to why we're beginning with interventions that are in supine, that are active range of motion, that are symptom titrated, and frankly might sound easier to the patient than they're used to if they've been to physical therapy or rehabilitation before. And lastly, we really want to differentiate between graded aerobic exercise or exercise and autonomic rehabilitation. As we said earlier, the concept of traditional approaches or graded aerobic exercise is not well tolerated for folks. And we want to hone in on the concept of autonomic rehabilitation as a progressive symptom titrated intervention that's aimed to slowly but surely increase tolerance and activity performance and participation in order to optimize quality of life. And so here are some references. And again, please take a look out for those appendix materials. And I thank you for your time.